7 after 9, this is The Breakfast Show on News Talk K-57. And an interesting conversation that we'll flip it up for a little bit with Dr. Paul Coty, who is a fellow over at the Guam Regional Medical City. What kind of equipment did they bring in for you to play with? You know, I had the lady from the hyperbaric chamber, and Auntie what's-her-name in here a little bit ago talking about some of the cool things they're going to be doing with that. Did they bring you any equipment to play with?
I don't use hyperbaric chambers.
No.
Right. Most of the equipment is mainly chairs, let's say, we call them infusion chairs for patients to sit in while they get chemotherapy infusions, that sort of thing. Okay, but no G-Whiz technology, nothing I might have seen on a television show that I can go, that's neat. No, medical oncology is about giving medicine, giving drugs, so we use patients sit in chairs that are comfortable. We have IV poles with little pumps that the medications are in bags and infused with the pump into the veins, so not too fancy, really. Well, it sounds like then we could spend more time on the creature comforts then. So we've got these great chairs. You know, I told you about the adventures in Cedars, and they had television sets in the rooms in Cedars that had more channels on them than the cable system that I've got at my house, because these things take some time. You know, the beginning and the delivery and the recovery, right? Right. Yeah. So you got to make sure, in the very least, Wi-Fi. I suppose for everybody to keep track of themselves. We're talking about prostate cancer in particular, but cancer in general, and where technology seems to be taking us, and where treatments seem to be taking us, and the promise of the tomorrows, where one of these days he may have to go and find another study in the field of medicine because we'd have cured prostate cancer or cancer in general. You think that's something that we might see in our lifetimes, Doc? I'm going to say no, but I would say maybe in 100 years. That long before we drill into, I mean, because we've got the DNA, right? I mean, we know what's happening at the cellular level, don't we? So we think that maybe in my lifetime what will happen is what's happened in HIV. In HIV, the HIV virus can kill a person within a couple of years, very quickly growing, causing the AIDS syndrome and death. And now you take 3 different drugs together, and the virus is put in check, and it's not gone from the patient, but it's put in check and doesn't cause any damage. So now people with HIV are living 20-plus years taking these medicines. So we think the best thinking now is that perhaps cancer will be that type of a situation. We'll find a cancer early, person will take 2, 3, whatever medications at the same time, and the cancer won't grow anymore. It'll just be this little tiny thing that's in the body and just sits there and chronic, but it ain't going to kill you. It ain't going to kill you. It's not even going to cause any side effects. The other parts of the conversation talked about we were yakking about remedies, and you perform your care here in the United States of America. There is a Food and Drug Administration, so some of the tools that you've got available to you have to go through an incredible screening and vetting process. Right. I assume. But there are other countries for which there is no FDA, and if they decide that we're going to be using the combs from the roosters to help cure cancer, then they don't necessarily have to go through that process. Now, and so the question I've got for you is, are there therapies that you see offshore, in Asia, or in Europe, or in South America, that you look at and you say, wow, I'd like to try that. That shows some interest. That shows some promise. Are there those therapies, and what do you do when you find one? So, at some point, an oncologist has to decide what kind of a pathway they're going to choose. So, if you're a medical oncologist, most medical oncologists will follow guidelines in the United States about what to do and what not to do. So, if there's some drug that's in Europe, let's say, that looks really promising, most medical oncologists will not find ways around the system to get the person that drug. They'll work within the system and prescribe what's FDA approved. They might discuss with a patient going to a country where the drug is available. For instance, there's one of the main drugs we use now in colon cancer was first in France for about 20 years. It took 20 years to get into the United States. And now it's a widely used drug in the United States. So there are There are treatments that are there are some treatments that are available in other countries that have yet to be approved by the FDA. But I think most doctors are sticking to what's available in the United States and waiting until further testing and approval by the FDA before using that in the United States.
There's and there's always the line, hey, just go across the border up to Canada and see what it is that they've got, what they can prescribe for you, and maybe you'll have some luck there. But go ahead.
Yeah. So one of the things about trying different drugs for cancer patients, I will say that when I was practicing in Hawaii, I think all of my patients took other kinds of medicines and anything they could find. When we do research, what we're doing is we're giving the drug to 1,000 or sometimes thousands of patients to see what happens to the drug in that person. So we're getting experience from lots and lots of people trying it. If something is taken just because it's available, you see it on the internet or your friend suggests it, you don't have the experience of hundreds or thousands of people taking the drug. In a sense, you're just seeing if the drug is going to work on you. It's sort of a research experiment where you're the only person. The problem is there's so many different things out there that are advertised. How would you know which one to take? And you don't have enough time when you have cancer inside you to choose. So
don't want to roll the dice on something that you don't know, that has not been tested on people in similar situations. Plus, you might be taking some medicine that might what's the word, conflict, contraindicate,
or interfere with some other medicines you're taking. So I think it's a more chancy, it's a less guaranteed scenario if patients who are just running around the world essentially trying to grasp on anything that might help them, whereas drugs that are approved by the FDA have been examined and tested on many patients, and so there's a greater likelihood. I think that's the bottom line, is there's a much greater likelihood that they'll work and help.
Dr. Paul Coty from GRMC, and he's here. We're talking about hematology, oncology, and medicine in the treatment, as I said, specifically with prostate cancer, but cancer treatment in general. And in your view, and depending on how Hollywood and the news portrays them, FDA, big bad FDA, or is it a good FDA? How do you view them? Should they speed up the process with certain drugs? Do you have patients coming to you saying, this is still in trials and I can't prescribe it to you, and things like that? Do you wish sometimes that it would go faster?
Actually, it has swung on, the pendulum has swung on the fast side of drug approval. So from the experience of HIV in the United States, there was a huge outcry to the FDA that drugs are taking too long to get out to the public. So the FDA now has fast-track programs where drugs are actually getting out very, very quickly. If there's no drug available, if the research seems promising, if the drug appears to be safe, they're releasing drugs with tremendous speed, actually, from the laboratory out to the patient. That's right. Only within a few months now, drugs are getting approved. It's been interesting. They're wondering if it's a good thing, because there's been a couple of different drugs where they were approved, patients were using them, and the FDA was waiting for the larger trials to come in, and then 2 or 3 years later, the larger trials say, hey, this drug didn't really work, and the FDA takes away the approval.
Oh, interesting.
That's right.
They would back it up, even though for some patients it was working.
In other words, if you just tested on 100 patients, you might see some good results.
Yeah.
And in certain cancers and certain conditions, the FDA will release the drug if there's no other option.
Yeah.
But then when they do the studies on hundreds of patients in different universities across the United States, and they find those results weren't real. And
hard to duplicate with a larger audience.
Right, and so they say, okay, we're withdrawing the approval. Interesting
statistics here that we're talking about. Then what about pharma? Big pharma, the industrial complex of medicine. And there's again, you look at Hollywood or how the media might portray them. Is it possible that there is a drug and a formula that's lurking in a laboratory computer database somewhere that they have not yet released because they don't have the profit model on it tweaked up just right in order to make the manufacturer and the marketing make sense? Anything to that when it comes to cancer drugs?
It's a huge...
we run a program called Coast to Coast, and every once in a while, we'll roll into some of that sinister thinking, and the conspiracy theorist will sneak in with me. And so I'm curious, do you find that maybe it comes down to pharma saying, well, you know what, we'll release the drugs, and we'll get them into the marketplace, and, after we've decided that there's a significant, a demand for it that will justify higher prices that the insurance companies will pay on behalf of the patients?
All of my friends ask me, do I think there's a pill that's locked up in a vault somewhere that cures cancer?
Yeah.
And, and they don't release it because they're making money on all the other drugs. Well, my only answer to that is, of course, I don't know. But I think the economic pressure would be to release the drug, because if there was a pill that could cure cancer, that drug would probably make $1 trillion.
It's right next to the patent that somebody's holding on cars that run on something besides gasoline and black oil, right?
That's water.
Yeah, it's the water, salt water, as a matter of fact. So we can run around with those things. Well, it's as I said, that's the way people talk. And we don't know, because we're laymen out here and looking for explanations. And this is not a cancer doctor question as much as it's a doctor question. And I'm sure you've seen some of the numbers as well. In the last 10 years, there has been a significant increase in the price of pills that used to cost 10 of them you could buy for $5 or $10, and now they're selling for $50, $100 for that same 10. Certain antibiotics and things like that have increased. I forget the name of it. If you give me a minute, I'll look it up. But something like 9,000-fold in just the last 10 years. Why are the numbers going up for those pharmaceuticals?
Yeah.
And they're everyday pharmaceuticals.
I'm not going to talk about everyday pharmaceuticals. Okay. I'm going to talk about the drugs I use to treat cancer.
Okay.
The big discussion, the big debate right now is the price of drugs. So when I started to practice oncology, to spend $1,000 a month on a medication was a lot. Then a drug came out that essentially put a cancer in remission, one particular cancer, and that drug cost $3,000 a month. And that was shocking at that time. It was jaw-dropping. One bottle of pills. One of my patients said he used to leave it on his coffee table and people would pick it up and read the price tag on the bottle. But now medicines cost $10,000 a month, many of them in oncology. And the question is why, and is this fair, and what do we do about it? Well, the industry, the pharma, the companies that make these drugs say we have to do research on 30 drugs, 50 drugs to find one that actually works. Yeah. And that it takes an investment anywhere from $1 billion to $10 billion of the company's investment money to actually find one drug that's going to work on cancer. So they're saying, why would we invest $1 billion unless we know we're going to make back 10 times that money? So they have to have a return on making the drug. The point is that if there's not a financial motive, drugs tend not to get developed. And so the U.S. government is trying to figure out, is there a way to tone down maybe the return on investment? Is there some in-between, something happy medium where they do get a return on investment, but maybe not charging $10,000 a month for a medication? Yeah, so
we'll still do that one for $3,000 a month, but we'll take some of these other things that are already out there and charge a little bit more for them. The drugs in question, the biggest increase, Doxycycline, and I don't know exactly what Doxycycline is good for. You're the doc, you do. That one in 2013, $20 a bottle. That same bottle in 2014, just 1 year, $1,849. It's a rather steep increase.
That's a big increase, yes.
What do you use that for again? Do you remember what Doxycycline?
It's an antibiotic.
There we go. Oh, I can't say anything because we had a conversation about antibiotics before that stemmed from an email that I got from another friend of mine, another MD that asked me to ask this doctor about fasting and EVOO and its relationship to cancer. EVOO, for anybody that watches the cooking shows, extra virgin olive oil. And is any relationship to it, fasting and extra virgin olive oil in the treatment of cancers, Doc?
There The fasting is very interesting. There's a couple of studies that looked at fasting in relation to giving chemotherapy, and there was some small studies that suggested that fasting perhaps before giving chemotherapy might improve the efficacy of chemotherapy. So it is being looked at and thought about, but that's not preventing cancer necessarily. There's discussion in terms of obesity and health. There's groups that feel that fasting is helpful in terms of overall wellness and well-being. And I think that's always a good thing if you can improve well-being. And extra virgin olive oil is certainly healthy for the heart. It's hard to say. I'm not aware of it.
There's any medical efficacy to that stuff as well.
I just want to say one other thing.
Please.
I always tell my patients they might bring various things into the office and say, "Doc, can I try this or take it or whatever?" And I tell them, well, it might not help your cancer, but it might make you feel better. It might improve your quality of life, and I think that's a good thing. I've had patients become vegetarians and patients who start running regimens and things like that, it's hard to know for sure if it's going to help their cancer, but certainly if it helps their overall well-being and quality of life, that's really important. There is along those lines, there are a couple of large studies that looked at women with breast cancer who had curative therapy, and those women that ate healthy meals, like the FDA food, the triangle meals, where it's like not so much meat and more fruits and vegetables, that kind of thing, and did moderate exercise 5 days a week, that they actually had better survival rates in their with their disease. And so we don't really understand the mechanisms, but we do know that eating well and exercising can help with recovery from cancer after treatments.
What's a part of the holistic programs and hospital facilities all across the country are now looking at at alternatives and alternative forms of helping people out when they have things like cancer. There's so much that you can do, so much that the surgeons can do, but maybe somebody coming in and teaching you how to meditate, maybe somebody coming in with Eastern methods and foods that might help you. If you feel better, if you've got a better attitude, there's a chance that maybe you'll follow along with some of the prescriptions and not be so down all of the time, which is an interesting segue into the next part of the conversation with you. Well, he cannot, I'll underline that a couple of times, speak about the medicinal marijuana laws here on Guam. You have participated in medicine in places where there is medicinal marijuana. In Hawaii.
That's right.
Did you actually? You can't prescribe it for your patient, but was that part of a recommended treatment pattern for treatment regime for your patients?
So at the time I was practicing there, what medical marijuana entailed is if a person had a diagnosis that met criteria, then the doctor can essentially allow them to possess a card that says that they can use medical marijuana. It would allow patients to grow a certain number of plants and to have on their possession small amounts of marijuana. The patient would have to use the marijuana in a private space. They could not do it out in public. It's not something that they could just walk around on the street. They would have to just do it.
Take their medicine there.
Right.
At the beach.
Right, exactly. They would have to do it in their house. It did not specify that the patient could go out and buy marijuana. There was no marijuana stores or shops. It was that the patient could grow the marijuana and could use marijuana. A lot of times patients who have cancer and had medical marijuana licenses, they would offer some of their marijuana that they were growing to other patients who were able to get this certificate who also had cancer. So there's a lot of questions about it and how it was going to work, but there were patients who were helped by it. I will say that there were a small number of patients who actually felt that it was very beneficial. It can help with pain control, and it can help with nausea, and it can improve appetite.
I imagine it also help them with certain anxieties that they might be going through if they've got something like cancer.
For some patients, yes, and other patients, no, because marijuana can cause anxiety.
When you're running out. What about dosages? When you talk to the patients, how do you dose them, or does that have to do with can they self-medicate? Do you trust them to do that?
There's never really a discussion about dosing. It never actually has come up in the office, interesting enough, and I've never read anything about dosing from the state of Hawaii in regards to that.
What about method of delivery?
Well, you talked earlier about Marinol. So Marinol is an FDA-approved medication. It's believed to be the active ingredient in marijuana, THC, tetrahydrocannabinol, and that comes in various sizes. So there's like 2.5 milligrams, 5 milligrams, 10 milligrams, etc. And in that case, there is an issue of dosing. So you discuss with the patient starting on a low dose, going up to higher doses, that kind of thing. So Marinol is available. What I've found in my practice is that patients who have smoked marijuana previously tend to want to smoke marijuana. They don't want to take the pills.
Right.
So I found that it wasn't very easily accepted as a medication. More patients were in Hawaii were choosing to get medical marijuana license and smoking marijuana.
There's 1,001 questions about what variety of marijuana would be available, and who got to make those kinds of choices, and THC counts and content, and all of that. If you don't, I got a couple of folks that have got questions for you, and if you don't, can I ask you to stick around just a little bit longer?
Sure.
It turned into I knew it was going to be an interesting conversation, and I hope you're having a good time with my questions. If you've got questions for Dr. Paul Coty, hematology and oncology at Guam Regional Medical City.